first of all, I'd like to thank the organizers for having invited me to present you this fascinating project, which started more than 10 years ago. So I'll try to get you through these 10 years and how it has progressed. I must say that I have nothing to disclose. So when we started, it was when the endoscopy capsule came out. And we had a look at the images. And as you can see here, of course, you can see the mucosa, that is what it's thought for, but you can also see intestinal contractions. So we thought that maybe we could measure motility using the capsule images. So first, obviously, we thought we would need to measure contractions. And to do this, we separated the video into individual images. The capsule takes 2 images per second. So these strips are 4-second strips. Let me see if I can do this right. So this is 4 seconds, and the contraction is characterized by an open lumen, which closes in the middle and opens again. What we saw is that not all contractions were occlusive. We also saw that there were many non-occlusive contractions in the small bowel. And we also saw that contractions had these wrinkles in the middle, which we thought had some relation to the force of the contraction. However, there were other things that we saw that we thought would be related to motility. We saw there were non-contractile patterns. We called this one the tunnel pattern, which is when the lumen is open and it's resting for a period of time. And we also saw this pattern, which we called the wall pattern, which is when the capsule is sitting watching the wall of the bowel. We also thought content would be important related to motility. We saw there were small bubbles of air, and other times there were turbid secretions in the bowel. And of course, we thought we had to measure movement of the walls. And I brought you a couple of examples. This one is content, which is moving fast, for example. Oops. And this one is a wall, intestinal walls that are not moving very much. So we had all these patterns or features that we thought we would like to measure, but as you probably know, an average capsule endoscopy video has about 3 hours, and if we have 2 images per second, we had about 25,000 images per patient. It was impossible to measure all these manually or visually. So we went to a group of engineers, also working in Barcelona, who are specialized in computer vision techniques. What are these? Well, computer vision techniques are actually quite present in the world we live in now, because we all continuously are working or looking at images and videos. What it does is it converts images into mathematical information which can be processed and patterns can be identified. For example, I'm sure all of your cameras or phones can identify faces, and that's based on computer vision techniques. Applied to our capsule, well, the engineers that helped us, they used a huge number of tools. This is one of them, the Laplacian Gaussian filter. This is to detect what they call blobs in image, which are black parts of the image. The tunnel pattern had a large lumen. This would be a contraction of smaller lumen, and the wall pattern, there's no blob there. Another tool they used was one that is mostly used in geography. It's applied to topographical maps to detect valleys and mountains, and they nicely detected the radial wrinkles that we saw in contractions. So after some hard work, because of course they needed our help to select all these patterns and give them lots of examples, they told us they had these tools to measure all these patterns, but of course then what we wanted to know was when this was normal or abnormal. So to decide if something is normal or abnormal in computer vision, what they use are machine learning techniques, okay? So these techniques are a kind of artificial intelligence which is based on algorithms that can learn and make predictions. These algorithms are called classifiers. So going back to our picture example, imagine our camera could also tell us if the face that it has detected is male or female, or maybe Japanese or non-Japanese. So it predicts and it classifies the images. These techniques, I know it's starting to get strange, this talk, but we should be familiar with them. This is a PubMed search for machine learning in the last 25 years. Exponential grow in the papers that have been published. Oops, wrong way. These are some examples from last year. Machine learning applied to ECG, machine learning applied to MRI to detect Alzheimer's, machine learning applied to children's faces to detect pain in their faces. And there are a couple of editorials here which are quite impressive. New England Journal of Medicine last year predicting the future, big data, machine learning, and clinical medicine. This JAMA last year worried about the profession of medicine, machine learning and the profession of medicine. So are machines going to start doing what we are doing? So it's an important topic. So going back to our capsule project, the engineers developed what they called a one-class classifier. How do these classifiers work? Well, you have to teach the machine what normal looks like, and it needs what they call a training set. So in our case, we used 85 healthy subjects, their videos, their capsule videos. Each of them, we extracted 43 motility parameters derived from those features I talked to you about before. And the computer learns a normal range, which actually has 43 dimensions, of what is normal, okay? So once the computer knows what a normal capsule looks like, you can give him new examples, which it hasn't seen before, and it decides if the new example falls inside the normal range or if it falls outside. So here, and it's when you test, the individuals you test are the test set. So here we tested 50 more healthy subjects that the computer had never seen, 19 severe intestinal dysmotility patients diagnosed by the gold standard manometry, intestinal manometry, and 200 functional bowel disorders, mainly IBS patients. These are, I put together several papers here that have been published in the last years. So these are the results in these groups. Intestinal motility analysis here, percentage of cases detected as abnormal, out of the normal range, and percentage of cases found inside the normal range. In healthy subjects, more than 95% were detected inside the normal range. In severe dysmotility, all except one of these 19 patients were detected as abnormal. And what we found especially interesting is that in patients with IBS, about 25-30% of the patients also had abnormal intestinal motility using this technique, which, as you know, is not detected by intestinal manometry. Moreover, we saw that these patients with functional bowel disorders and abnormal motility using the capsule fell into two different clusters. A subgroup of these patients were hyperdynamic. They had more occlusions, more intestinal occlusions in their capsule. They had less static sequences, periods where the capsule wasn't moving, and they had more images with radial wrinkles. And on the other hand, we had a hypodynamic cluster, which were patients where there were more static sequence, less luminal occlusions, and less wrinkles in those occlusions. So more recently, we applied a new kind of analysis to all these features. Previously we were detecting individual events throughout the video, but we thought it would be interesting to find periods where one of these events predominated or it was in high frequency. So I'll get you through this because it's not easy to understand. This is a healthy subject. This is whole capsule video, a whole small bowel. And what the computer has done, it has detected periods where a phenomena predominates. In red, it's when it is contractile periods, and in blue, it's static periods. I haven't told you before, but for this test, we give the patients and the volunteers, we give them a liquid meal. We always give it 45 minutes after the capsule has left the stomach. So as you can see here, when the healthy subject receives the meal, the intestine starts contracting, and you see these contractile periods as the capsule is moving down the small bowel. This is a case of a hyperdynamic patient. It's obvious that the video is shorter, so the capsule moves faster down. And also you can see that the whole video is full of contractile periods and almost no static periods. And last, this is a hypodynamic case. This patient has a normal length video, but the bowel is not moving. It has very few luminal closure periods or contractile periods, and most of the video, even before the meal, but also after the meal, is mainly static. So the bowel is not contracting as much as a healthy person. These are just examples, but we applied this to a large group of patients and healthy subjects. As you can see here, 48 healthy subjects, 13 hyperdynamic cases, and 38 hypodynamic cases. In green, healthy subjects, in red, the hyperdynamic, and in blue, the hypo. This is the percentage of the video corresponding to luminal occlusion sequences. And we measure this before the meal, and we divided the post-meal period in 3 equal parts. So as you can see, after the meal in healthy subjects, luminal occlusions increase, and they decrease throughout the video. But hyperdynamic patients have a larger response and much more sequences corresponding to luminal occlusions, and hypodynamic cases are on the other side. They have few contractions. Other parameters that we measure, static sequences, it's the opposite to luminal occlusion. So hypodynamic cases have many static periods in their videos. Hyperdynamics have almost none or very few. Tunnel sequences, these are very predominant in patients with hypodynamic behavior. And static content sequences, this is content that's sitting in the bowel and not moving. Everyone has it, especially in the terminal ileum. This is the healthy subjects. As you can see in the last part of the post-meal, we encounter these static secretions, but they're much increased in hypodynamic patients, and hyperdynamic patients don't have any of these static secretions sitting in the terminal ileum. So all of this was starting to get quite abstract. It was sort of a black box approach. We were giving the capsules to the patients, and we got this result of normal, abnormal, and we thought we should take advantage that we had these images of the bowel, and it would be nice for us to see what is going on. So together with the engineers that have worked with us, we developed what we call the motility bar, which is just actually a visualization technique. It's a way we can see all these periods and things that are going on in the bowel. So how do we construct this motility bar? We take one strip from each image. It's a 1 pixel wide strip, and we place these strips one after the other, and we get this kind of images. So this is 10 minutes of video seen in just one image. Okay? So some examples of these features that we've told you about before. Contractile activity. This is the individual images, 5 images. This is 10 minutes of contractile activity. It gives you this sort of tiger-like pattern because the lumen is opening and closing. This is the tunnel pattern. You get this static large black lumen here and a clear wall that stays the same in the motility bar. This is a static period, quiescence. The image is constantly the same, so you don't see changes here. And this is a turbid sequence where there's secretion, so you get this green image inside the bowel. So going to a real example, this is a motility bar of a whole video in a hypodynamic case. So each row is 60 minutes of video. This is where the capsule enters the small bowel. This was gastric. I'm not showing you this. It travels down the small bowel this way, and here it's when it exits the bowel and enters the cecum. And here you have when the patient received the meal, which is 45 minutes after small bowel entrance. Here the color code is switched. Contractile activity is seen in blue and static is seen in red. So now we have the image and we have the period, the sequence analysis below in color. So it's very nice to see how before the meal, here the bowel was sitting quietly without moving. Here's some contractile activity. After the meal, there was not much contractile activity. Remember, it's a hypodynamic case. Here are some tunnel sequences in purple, and here is some content sequences in green. So all these abstract things that I was talking about, now you can see it in just one image. And this is a hyperdynamic case, which is the other extreme, with the other side, which is mostly contractile activity, short video. The capsule is moving fast through the bowel. So to summarize, until this point, what we've developed is a non-invasive, computerized, objective technique, which is equivalent to intestinal manometry to detect severe intestinal motility disorders, and it also detects intestinal dysmotility in a significant proportion of patients with functional bowel disorders. So now what we are working on is applying this technique to other kinds of patients, which we think have not been properly studied, probably because intestinal manometry is an invasive test. There are very few centers that perform it. So many diseases where we suspect there is intestinal dysmotility have not been properly studied. So we started with some groups of patients, which our hospital is a reference center for them, and that's why we had them, and it was easy to start with them. We started with common variable immunodeficiency. Just very rapidly, there are two phenotypes in this disease. One phenotype has more infections but does not have other complications, and the other phenotype of patient has infections but also has autoimmune, inflammatory, lymphoproliferative diseases, and these are the enteropathy patients, the ones that have malabsorption. However, digestive symptoms are prevalent in both phenotypes, and it is unknown if small bowel dysmotility is involved. It's suspected, everyone says it, but nobody has demonstrated it. So we did our capsule test to 14 patients. 4 were the phenotype 1, and 10 were the more complicated phenotype 2 patients. They all had previously been studied by endoscopy with gastroscopy or colonoscopy. 40% of them had abnormalities with conventional endoscopy. The use of the capsule, of course, we measure motility, but we can also look at what we're seeing in the mucosa. All of them had abnormalities when we use the capsule, We found this kind of abnormalities. They had marked nodular lymphoid hyperplasia in 50% of these patients, and the other half had this very severe mucosal atrophy that was sometimes low down in the jejunum and had not been detected previously. And of course, we also did our motility test, and what we found is that 60% of the phenotype 2 patients also had hypomotility. We didn't have any hypermotility cases. These are some of the features that we measure. Patients with hypomotility had less contractile activity in their bowel. They had more static sequences, more retention of intestinal content inside their bowels. And last, we actually have a poster today about this, but I'll just mention it very fast. We've also studied some patients with cystic fibrosis. It's a lung disease, but it also affects the small bowel. It's due to a dysfunctional chloride ion channel. The intestinal manifestations are very typical. In the newborn, it's the meconium ileus, and in the adult, it's the distal intestinal obstruction syndrome. And these patients, we did a group of 10 patients, I think it is, and 70% of them also had hypomotility when we used our capsule. They had less luminal occlusions, less wrinkles in their bowels and in their contractions. They had more static sequences, and they also had an important retention of static intestinal content inside their intestines. So here we demonstrated that there is small bowel dysmotility in these patients, which I insist had not been previously seen. So just to conclude, our future studies and what we're working now is on using this dual function the capsule can give us, which is seeing the mucosa and also measuring the motility and trying to relate them. So the dual organic functional disorders of the small bowel in patients with systemic diseases which have not been previously studied. That's all. Thank you for your attention.